So I will sort of try to answer the question, what implication for the diaphragm, what's the impact of spontaneous breathing on the diaphragm. And actually, it will be a talk about the good and the bad. And I will show you that spontaneous breathing does some good things to the diaphragm, but can also do some bad things to the diaphragm. Here are my disclosures. So if we consider the course of ICU stay of a given patient, then first the patient is admitted to the ICU and he has an acute respiratory failure, so it's a high respiratory rate, respiratory distress, and then you decide to intubate the patient. It's very severe, it's controlled mechanical ventilation. Then improves, then switch to pressure support, then it's great, it's getting better, and then the patient is extubated. So the first thing that we know now is that all this mechanical ventilation there will cause an ICU-acquired diaphragm weakness that we call ventilator-induced diaphragm dysfunction. So the fact of giving mechanical ventilation to a patient will cause diaphragm dysfunction. This ventilator-induced diaphragm dysfunction is basically a time-dependent decrease of diaphragm strength, as elegantly demonstrated by Samir Jaber's team. Here you have the twitch diaphragm pressure, which is a nice surrogate of diaphragm strength in a few patients. And here is the beginning of mechanical ventilation, and you see that days after days, the diaphragm strength is decreasing. So as soon as we start mechanical ventilation, we unload the diaphragm, and this creates diaphragm dysfunction. Why? Because there's this unloading causes myofiber injury and myofiber atrophy. This atrophy has been also very elegantly observed by the team from Levine. They compared patients who had like 2-3 hours, very short mechanical ventilation for surgery, and some other patients who had prolonged mechanical ventilation. And they show that in patients with prolonged mechanical ventilation, the size of the fibers was highly reduced, and there was severe atrophy. And more recently, using ultrasounds, Ewan Golliger shows that here on the y-axis, the percentage of change in diaphragm thickness was decreasing as a function of the duration of mechanical ventilation on the x-axis. So the longer the duration of mechanical ventilation, the more severe the loss of diaphragm thickness. So if the diaphragm rests, then the diaphragm kind of melts. It's actually what happened to Schwarzenegger. He was training as Terminator and started resting as a governor, and then no muscle. So what the mechanism involved there? There's two mechanisms that links diaphragm unloading and myofiber atrophy and injury, and those are oxidative stress and protein synthesis proteolysis imbalance. Very nice here in these words. The authors studied the proteolysis in animals, control animals like spontaneous breathing, and in animals who were submitted to controlled mechanical ventilation. And they show that with controlled mechanical ventilation, there's a huge increase in proteolysis. And concomitantly, there's a huge dramatic reduction of protease synthesis. So these rests of diaphragm just destroy the fibers, and there's no building of new fibers. So now we have all the process. Then we can think about how to prevent it. So we can give a lot of various medication that will fight each of those mechanisms. But let's be honest, I hope I will see this, but we are not completely ready for that. And from now, we have only one option, is promoting partial modes of mechanical ventilation. And the same authors, you remember, they showed that controlled mechanical ventilation increased proteolysis and reduced proteosynthesis. And they showed that as soon as the animals are switched to pressure support ventilation, then it was preventing the proteolysis and it was improving proteosynthesis. So there's something there with promoting the partial modes of mechanical ventilation. Actually, in the very nice study from Golliger, they look at the impact of contractile activity of the diaphragm. So they measure the intensity of the contractile activity of the diaphragm every day. And they showed that the more the diaphragm was contracting spontaneously, the more it was preventing the change in diaphragm thickness. So promoting spontaneous ventilation, making the diaphragm contract spontaneously will prevent this change in diaphragm thickness. So you take the governor and back to the gym, and then the muscle will be back. And this is probably the good things that we can do to the diaphragm by promoting spontaneous ventilation. And this has been nicely described last year in a paper from the team from Zambon. They compared the change in diaphragm thickness of patients, mechanically ventilated, and they classified them in 4 different groups. Those who were fully spontaneously breathing or having just CPAP, those with a low level of pressure support, those with a high level of pressure support providing more unloading, and those with a very high unloading like controlled mechanical ventilation. And what they showed is with basically no unloading, there is no change in diaphragm thickness. With a low level of unloading, it's okay. But as soon as unloading becomes important, then there's a high change in diaphragm thickness, and the thickness of the diaphragm decreases. And this is more important with controlled mechanical ventilation. So here is the good. If we promote spontaneous ventilation in our patients, then we will prevent the thickening of the diaphragm and then the diaphragm dysfunction. And we don't want diaphragm to be severely weak because it's going to compromise weakening from mechanical ventilation. Now, let's see the bad. So, we talk about all this period. The patient receives mechanical ventilation, and mechanical ventilation is weakening the diaphragm. But what happened before the patient was intubated? When he was spontaneously breathing, there was sepsis, there was shock, and maybe some bad things happened to the diaphragm. And very recently, my team and Samir Jabanswan studied the strength of the diaphragm right after intubation, 24 hours after intubation. And we were very surprised to observe that in 64% of patients, there was a weak diaphragm. In 64% of patients, right after intubation, the diaphragm is weak. And the 2 independent risk factors for this acquired diaphragm weakness were the severity of the patient, like high SAPS2, and the sepsis. So maybe something happened there. Before intubation, something bad happened to the diaphragm. This sepsis, the fact that sepsis can damage diaphragm is very well known now. Here is a nice work from Basil Petrov's team in Montreal, and they compared the Myofiber's injury in diaphragm and soleus. The white bars are the control diaphragm, and the hash bar are those with the sepsis, with endotoxemia. And what they observe is that compared to the control diaphragm, the diaphragm of septic animals were severely damaged. All these white dots are damaged muscles, damaged myofibers. But what very interesting, what they observe is that the extent of diaphragm injury was much higher, the diaphragm of muscle injury was much higher in the diaphragm than in the soleus. So there is something very specific that happens to diaphragm and that does not happen to the soleus. So what happened? There's a sepsis, inflammatory mediators, and then myofibers injury and diaphragm dysfunction, but only diaphragm, not soleus. So why? So to start answering this question, they compare control animals against septic animals, and as planned, they observe here is the force of the diaphragm on the y-axis, and they observe that in the septic animal, there was a very important diaphragm dysfunction with major diaphragm injury, white dots, as compared to controls. But they made a third group. The third group was septic animals, but with mechanical ventilation, to try to answer is the fact that the diaphragm was contracting in a very septic environment and inflammatory environment was causing damage. And what they observe is that providing controlled mechanical ventilation at the very early phase of sepsis was partially preventing this sepsis-induced diaphragm injury. So maybe here, spontaneous breathing does bad things. To start understanding better the whole picture, they did muscle cell culture and they stretched those cultures, like stretching the cell culture. And they measured oxidative stress. And what they observed is that oxidative stress was much higher when there was an important strain than where strain was basically very low. So stretching a muscle when there is inflammation creates damages to the muscle and creates oxidative stress. So here is the possible picture. There is cyclic contraction of the diaphragm, cause mechanical strains, and then creates sarcolemma, hyperfragility. And then this very fragile diaphragm is hit by the sepsis and the inflammatory mediators, which creates myofiber injury and diaphragm dysfunction. And this is probably worsened by inspiratory loading. And that's another very important information. In a study that's quite old now, the investigators took COPD patients, and they compared them to control patients, and they submitted these patients to inspiratory loading. So the 4 groups: controls, no inspiratory loading; controls, loading; COPD, no inspiratory loading; and COPD with inspiratory loading. And you can see that what they observe first is that as compared to normal fibers in electronic microscopy, after loading, there was very, very serious damage to fibers. And the other very important message here is that when there's inspiratory loading, it increases diaphragm myofibers injury. So loading creates injury. So when the patient is in respiratory distress and breathing very frequently, there's a huge load to the diaphragm, and then it creates more and more injury. And this injury is mediated by pro-inflammatory mediators, as shown by those authors who measured the cytokines after inspiratory loading, and they are highly increased. So the final picture is we have the cyclic contraction of the diaphragm leading to myofibers injury, but high inspiratory loading also creates fragility of the diaphragm and inflammatory mediators. And this we don't want in our patients. We don't want sarcolemma to be targeted. And the message here, do not pump iron in the middle of the gunshots. So the diaphragm should not work a lot when there is a very pro-inflammatory environment. This is bad. So, as a conclusion, when the mechanical ventilation is recovering, Spontaneous breathing prevents ventilator-induced dysfunction. It might be beneficial, and the use of partial mode of assistance is encouraged. At the early phase of a critical disease, the diaphragm is extremely vulnerable to sepsis, and spontaneous breathing might increase diaphragm injury, and the diaphragm should rest, or there will be what we could call a myotrauma. Thank you very much for your attention.
Thank you very much, Alexandre. Is there any burning question? Maybe just tell us what would be your ideal monitoring?
My ideal monitoring, you mean for what? For the diaphragm strength? Or here? I would use probably ultrasounds as a first-line monitoring because it's very convenient and we have it at the bedside, so I would use that.
Okay. If there is not any further question. Yeah, last question, please.
Yes, hi, congratulations on the presentation. Regarding the concept of rest for the diaphragm and having into account that we know that sedation and deep sedation in the early phase of critical illness is bad for the patient, I would like you to comment on how to get that rest concept to the diaphragm without the noxious effect of sedation in the patient.
I think that the patient, when the patient is very severe, he has to receive sedation and to be very passive and passively mechanically ventilated. And as soon as the patient improves, then he has to be waked up and start breathing spontaneously. The issue is to find the right time points. So to decide, right now the patient goes better, and then he has to start breathing spontaneously. But when he's severe, sedation and controlled mechanical ventilation.
Thank you so much. I think